Assalamu alaikum. Bismillahirrahmanirrahim. I will thank Dr. Wahman for the kind invitation and Prof. Dr. Sami, Prof. Dr. Walid, Prof. Lamia. PET-CT and prostate cancer. Prostate cancer is the most common male malignancy worldwide and is the second most frequent cause of cancer-related mortality in men globally. It can exist along a wide spectrum of aggressiveness and severity from indolent, very low risk, localized prostate cancer to life-threatening, very high risk metastatic disease. Following definitive treatment for clinically localized prostate cancer with either radical prostatectomy or radiotherapy, guidelines recommend monitoring patient for recurrent disease by measuring the PSA serum level. Imaging modalities for prostate cancer. Conventional imaging modalities, accurate assessment of extent of disease, essential for guiding treatment decisions. Technetium imaging bone scans, CT and MRI have traditionally been used in patients at high risk for metastatic disease. However, conventional imaging modalities have limited utility in patients with PSA serum level lower than 10 nanogram per milli. In addition, CT and MRI face significant restriction as they fail to detect lymph nodal lesions less than 8 millimeter, and consequently lymph nodal secondaries are missed, especially in high and intermediate risk patients. PET-CT imaging. PET-CT imaging involves three subtypes: increased proliferation-based PET imaging, carbon 11 and fluorine 18 choline, and fluorine 18 fluocyclovine PET-CT. The second type is receptor-targeted PET imaging, PSMA PET-CT, and the third subtype is metabolic activity-based PET imaging, F18 FDG PET-CT. We will mention each category or each subtype in details. The first is increased proliferation-based PET imaging. C11 and F18 choline is a precursor of phospholipid, a major component of cell membrane, so increased incorporation in cell proliferation, which is increased in prostate cancer. FDA approved for detection of biochemical recurrence of prostate cancer in 2012. And the second tracer was F18 fluocyclovine. Fluocyclovine is an amino acid analog, and again it increased uptake in cellular growth, and FDA approved for detection of biochemical recurrence in 2016. However, both have limited specificity due to false positive uptake, inflammatory lesion, benign tumor, and other malignant tumor. In addition to that, the diagnostic performance decreased with PSA level lower than 2 nanogram per mil. The second subtype of PET imaging is receptor-targeted PET imaging, PSMA PET imaging. The unique characteristic of PET-CT is its high detection rate of metastasis even at low pre-PET PSA level, so it's overcome the previously mentioned tracer. NCC guidelines for 2021 recommend PSMA PET-CT imaging for initial staging and to detect recurrence after primer treatment. So, what is PSMA? PSMA is type 2 transmembrane glycoprotein located on the epithelial cell of the prostate. The overexpression of PSMA in most prostate cancer, greater than 90% of prostate cancer, and reaching up to 100 to 1,000 times greater than normal prostatic or benign prostatic tissue, and the ability to internalize make it an ideal target for diagnosis and therapy. It has also a limited extra prostatic physiologic expression, lacrimal, salivary, neuroendocrine tissue, small bowel, and kidney. This is a physiologic PSMA biodistribution. PSMA target diagnostic radiopharmaceutical, either gallium labeled PSMA as gallium 68 PSMA 11 or fluorine 18 labeled PSMA such as F18DC FBC, which is the first generation of a fluorine-labeled PSMA tracer. Then F18DC FBYL, which FDA approved in 2020, and F18 PSMA 1007. Regarding detection rate or the difference in detection rate between gallium labeled and F labeled PSMA tracer, although if fluorinated PSMA tracer has favorable physical properties, however, the detection rate, as we see, not significant between the two tracers. طيب يعني في الابروبريت يوز كرايتيريا فور بي اس ام اي بت ايميجينج classified the indication for PSMA PET imaging in a clinical scenario rather than indication, and published in 2022 and included representative from multiple international societies on top of Society of Nuclear Medicine and Molecular Imaging, ASCO, and European Association of Nuclear Medicine. This clinical scenario classified into three categories. The first class, 1 to 5 scenario related to initial staging, 6 to 8 scenario related to biochemical recurrence, and 9 to 12 related to advanced prostate cancer or castrate-resistant prostate cancer. We should mention that this scenario or utility of PSMA scale scored on a scale from 1 to 9. 1 to 3 scored are rarely appropriate. 4 to 6 as may be appropriate, and 9 to 12, 7 to 9 as appropriate. The first scenario, patient with suspected prostate cancer by high or rising PSA level, abnormal digital rectal examination result to evaluate target biopsy and detection of intraprostatic tumor. The appropriateness of PSMA in this clinical scenario is score 3, rarely appropriate. Why rarely appropriate? Because the PSMA expression is heterogeneous and BB negative, both in primary tumor and metastasis, between 5 to 10%. As we mentioned previously, that PSMA is expressed in greater than 90% of prostate cancer. However, the small percent, 5 to 10% of patients not expressing or tumor not expressing PSMA. However, may be considered in some setting when multiparametric MRI results are inconclusive or rare biopsy results are negative. Such as this case with PSMA positive focal prostatic lesion, SUV max of 12. The patient had a multiparametric MRI and reported as PIRA2 on MRI. And based on the PSMA result, confirmed to be prostatic cancer on biopsy. The second scenario, I will remember that the first 5 scenario related to initial staging, diagnosis and initial staging. Scenario number 2, patient with very low and favorable intermediate risk prostate cancer, rarely appropriate. Why? As imaging is generally not indicated in the NCCN guidelines, observation or active surveillance is often the preferred initial management of such patient. Scenario number 3, newly diagnosed unfavorable intermediate high risk or very high risk prostate cancer, score 8, appropriate. There is supportive high level evidence in this clinical setting that PSMA PET is more informative than conventional imaging. This patient underwent PET CT, high risk patient underwent PET CT. The CT component of PET CT scan show unsuspicious pararectal lymph node 3 millimeter, while PET revealed positive PSMA uptake, so it is suspicious and confirmed on histopathological examination to be lymph nodal metastasis. The fourth clinical scenario is the newly diagnosed and favorable intermediate or high risk or very high risk prostate cancer with negative equivocal or oligometastatic disease on conventional imaging. Score 8. Why? At BISMA, PET may identify site of disease not detected or equivocal on conventional imaging because higher sensitivity. Oligometastatic disease on conventional imaging may in fact be polymetastatic, which have an impact on subsequent clinical management decision. Metastasis-directed therapy for oligometastatic disease versus systemic therapy for polymetastatic disease. The improved specificity, on the other hand, the improved specificity of PSMA PET may reclassify some patient with oligometastatic bone scan finding as false positive and downstage patient with this finding to M0. Example of patient underwent bone scan. There are few scattered bone lesion. Within 1 week, the patient referred to do PSMA PET-CT to exclude or assess visceral metastasis, and this is the actual distribution of bone mix. So it is appropriate to do PSMA PET imaging patient with oligometastatic disease on conventional imaging. This is the last clinical scenario in initial staging category, newly diagnosed prostate cancer with widespread metastatic disease on conventional imaging. Score 4 may be appropriate. Later evidence that PSMA PET will add any additional value or have management implications in clinical scenario, and the patient is already has wide metastatic disease. The next 3 clinical scenario related to biochemical recurrence. سيناريو 6 and 7 هنحل مكتوب في بعض. هو سيناريو 6 اللي هو PSA rising after radical prostatectomy، وسيناريو 7 PSA rising after radiotherapy. Score 9 appropriate. After initial curative treatment, either radical prostatectomy or radiotherapy, up to 1/3 of patients develop biochemical recurrence, and 50 to 95 of cases with high risk will experience biochemical recurrence. What's the definition of biochemical recurrence? Defined as a rising PSA value above 0.22 nanogram per milli in patient treated with radical prostatectomy, or a PSA rise of 2 nanogram per milli or more above the nadir value following radiotherapy. Biochemical recurrence signal locally recurrent disease or metastatic or both. The high sensitivity to PSMA PET in localized recurrent disease has been shown to significantly affect clinical management. So it given score 9. This patient, a high-risk patient with biochemical recurrence after radical prostatectomy, a current PSA of 1.3 nanogram per deciliter. As we can see, a PSMA fused PET-CT image show local recurrence. Detect the site of recurrence, which is a local recurrence. Scenario number 8. The last scenario in biochemical recurrence, PSA rise after focal therapy of primary tumor. Score 5 may be appropriate, as after focal therapy definition of biochemical recurrence is unclear. Most patients treated with focal therapy have low-grade disease. So the panel was not fully supportive of this indication. The next 3 scenarios related to advanced disease or castration-resistant prostate cancer. Clinical scenario number 9, non-metastatic CRPC on conventional imaging. Score 7 appropriate. Approximately 55 of patients categorized as non-metastatic CRPC by conventional imaging were recategorized as metastatic CRPC by PSMA PET. So it is scored 8. Or appropriate. This patient initially diagnosed as non-metastatic CRPC and on bone scan and diagnostic CT simultaneously done. However, on PSMA PET imaging there is bone metastatic, so up staging أو patient recategorized as metastatic CRPC. إذا السيناريو خلصنا؟ لا ما تقولوش. طيب ما فيش عندي 5 دقايق ولا حاجة؟ طب كنت عايزة أقول بس الرول أوف FDG ما فيش دقيقتين ولا